Looks like we're streaming on Facebook now.
Okay, we are on. This is fantastic, and it was very cooperative with us tonight. Well, welcome, welcome. Let me see you. Make sure I got you on my computer here too. Yep, all is wonderful. So, Dr. Jennifer Simmons, thank you very much for coming back again. We had such a great time last time. We could have gone on for more, so we actually came back for more.
Yeah.
So tonight is a lot about breast cancer, and I'm getting questions from my patients that come in. They question about second opinion. They question about the BRCA gene. They question, why aren't we doing MRI for the breast? I remember for a while, MRI of the breast was being done, and then I heard it was getting so specific, and maybe you can talk about it, that I heard and read that because it was so specific, it led to many biopsies that were then false negative, and now they kind of took a backseat to that. I want to make sure I understand that correctly.
Mm-hmm.
So welcome. If
Thank you.
people who didn't get a chance to listen to this before, can you share your background?
I can. So I started off my career in medicine as a breast surgeon and worked as a breast surgeon for about 17 years. And when doing that, was very much focused on finding a silver lining for my patients, and really used as cutting edge treatments and therapies as I knew about as a traditional medical doctor. And in about my 15th year of practice, I got sick. I was diagnosed with my first autoimmune disease. And really that started my journey just to heal myself, to see if there was another way, because I didn't want to do the things that were recommended for me. So I was being told that I either needed to have my thyroid gland removed or have radiation or do all of these things, which I readily recommended every day to my breast cancer patients. But somehow when it came to me, it didn't feel right. And so that started my healing journey for myself, which I learned about functional medicine and used functional medicine to cure myself. I had another autoimmune diagnosis along the way, but I really, it was a journey. It was a process. It took me 3 years really to heal myself. And when I did, I realized that I shouldn't have a different standard for everyone else that I didn't have for myself. And I made a decision to leave surgery and practice functional medicine, where I now help primarily women with breast cancer, but not exclusively. I help them to determine what got them there and to help remediate that and to go on and live the healthiest life that they can.
Fantastic. Excellent. So with that as our start, we're talking about 10 things that we're going to share tonight. And the one thing I want to talk about to start off with is from the beginning, and it's testing. So with respect to testing, I want to talk about sensitivity, specificity, and reliability. So from mammogram, that's a regular mammogram, to a 3D mammogram, and ultrasound, and then when do we make the decision to get the gene test, get the BRCA1, BRCA2 gene test, and what role does that play? So if we can start with that as our base, and then we'll move forward going forward.
So I want to start by saying, because I think that this is something that everyone confuses. Early diagnosis is not prevention. Screening is not prevention. Prevention is one thing, and prevention is really what I am trying to scream from the rooftops. But early detection only gives an advantage of intervening once the problem has already developed. Whereas prevention is about intervening so that you don't have the problem develop. But that said, this country's medical system is not based on prevention, it's based on intervention. So we have an early intervention program that we call screening. And right now, the accepted mode of screening in the general population is mammography, and nothing else is approved for general population screening. Now, the sensitivity of mammography, how likely it is to pick up a lesion, is very variable depending on age, breast density, that kind of thing. So in a fatty breast, we're able to detect an abnormality nearly 100% of the time. In a very dense breast, in a breast of a woman who does not have a lot of fat in her breast, she's young, she's premenopausal, she has a lot of glandular tissue, and that may extend for someone well into old age. There are just some people that have very glandular breasts. And so their sensitivity on these screening examinations is going to be much lower. So, the range that is quoted is somewhere 70 to, somewhere around 70% all comers for sensitivity in being able to pick a lesion once it is greater than 5 millimeters in size. We have a threshold for about 3 millimeters. There's sometimes when we can pick up a 3 millimeter lesion, but it mostly requires a 5 millimeter size lesion for us to pick up. Now, that's the general screening population. There's obviously people who are going to be at increased risk. You mentioned people who should be tested for BRCA, and we'll talk about that. But there are people who are at increased risk. Either they've had a family member who was diagnosed very young, or they have a number of family members with breast cancer. So those people are at increased risk. And so for those people, screening needs to be more individualized. There are no general societal rules that are going to apply to those people. So you can't say, well, you have a family history, you should just start screening at 40 with everyone else. You have to look at them, see when their relatives developed breast cancer, and generally back up about 10 years from when their relative developed breast cancer. So it's really about looking at the person, having this conversation with your doctor and letting your doctor know, this is my family history, these are my risk factors, and I want to know what the best screening program is for me. And that really needs to be developed in cooperation and partnership with one another. There are plenty of people for who MRI is appropriate. Yes, MRI is very sensitive. It does lead to a lot of biopsies that end up being negative, that end up being benign. So it does put people in a position to have more procedures, put people in a position to have more anxiety, because the more procedures that you have, the more anxiety you're going to have. So there are definitely harms and drawbacks associated with MRI. That said, it's going to find more cancers than a mammogram will, for sure. And you just have to decide, on which side of the line you want to stand. Would you rather, if you're at risk, would you rather know about it? And that's pretty much it. Now, you can't just be worried. There has to be some reason to put you in that MRI screening pool. There are criteria for which you enter into that MRI pool. But for the most part, it is going to be your choice too. And there are a lot of people that don't want to screen with MRI. It's not a benign procedure. You have to get an IV, you have to get contrast. There's a possibility of reaction to that contrast. It's time consuming, it's expensive. And not everyone wants to, and you have to go in the tube, as everyone says. There's no open MRI for the breast. It's done prone, it's done lying on your stomach. Not everyone is comfortable in that position. So, it's not nothing.
So one of the things that, we always preach is the soft breast exam. And, there's always that one patient that sticks in your head. And the one patient that, sticks in my head with relation to this presentation, it was just a simple conversation, just treating her for some upper thoracic pain that she came in with. And she shared, she's like, I have an inverted nipple. And that was one of her concerns. And obviously this is out of my scope. And it's kind of like, you better get that checked now. So as you can imagine, it did not lead to a positive outcome initially because she was diagnosed. And that's where we're always careful when somebody says, I have back pain, because not all back pain is back pain. It can be from something else.
Of
and,
course.
we got her to the right folks and things turned out really well for her. So,
Hmm.
can you talk a little bit about the self breast exam, and then we can go from there to the staging?
Absolutely. Now, I'm coming from a bias where I absolutely believe in self breast examination. And I believe in it for several reasons. First, I believe that are our best own doctors, and you know when something is different, wrong, out of sorts with your own body. So I believe that we all have a responsibility to know our own body so that we can know when something's off in our body. Beyond that, general population screening starts at maybe 35, maybe 40. Oh my goodness gracious, I'm so sorry.
That's okay.
My husband left his phone at home. Um, so if you are not getting your first mammogram till 35 or 40, but there are plenty of breast cancers in the 30 to 40 range, and that's assuming you even start at 40, because I think that the best screening we do, the best percentage is somewhere around 55% of women who are eligible for mammograms. So not even everyone who's eligible is getting one. So almost no 35 or 40-year-olds are getting mammograms. So the way that they're finding breast cancers is by self-examination. And I think just because the US Prevention Task Force decided that self-breast examination causes anxiety, I don't think that that's a reason to tell
I
women
did not
not.
hear about that one. That was
They said that there was no clinical evidence to support doing uh, self-breast examination, and that statistically speaking, it did not lead to a reduction in mortality for breast cancer, and so they warned against it.
wow.
Um, I think that women should absolutely know their own breast. I think that they should be doing self-breast examinations. Um, and that includes both looking at your breasts to find dimpling, nipple inversion, something like that, and also examining your breast, running your hand over your breast every month. It's very important.
Now, the
And
self breast exam for men as well, too, because we're hearing
absolutely.
men who now would you say that the prevalence of male breast cancer is rising,
Um,
or are we just detecting it
it
more?
it's such a rare breast cancer still. I mean, it's still one in every 1,000 or 10,000 breast cancers. I think it's one in every 10,000 breast cancers is in a man. Um, I started to see more in my practice as I was, in practice longer. I don't know if that's a function of just being in practice longer, but remember, we are surrounded by xenoestrogens. So these are chemical estrogens that, they're in our cookware, they're in our plastic, they're in our water, there are in the things that they use for pesticides, or in cleaning products in your house. And all of these behave like estrogens in the body. And, they're not exclusively behaving like estrogens in women, they're behaving like estrogens in men too, which is why we are going to see all estrogen associated diseases on the rise.
Right. And like our from makeup to body
Everything.
soaps to everything. I don't know how I don't know if one can totally escape that. You can
You
surely
can't.
take the actions to diminish it, but I don't think you can
Right.
totally escape that.
You're not going to escape it, and you can't live in a vacuum.
Right.
But what you can do is diminish it. So you can store your food in glass and not in plastic. You can choose to not drink out of plastic bottles. You can clean your house with natural products like vinegar, lemon water. You can not use a whole bunch of commercial products. You can, choose one or two safe products to use, get one organic shampoo and just use it on everything. And so, there are ways to diminish that toxic load. You're not going to eliminate it.
Right. Right.
But there are certainly ways to diminish it.
So that leads us to, okay, you've been given a diagnosis. So can we talk about the staging of breast cancer? What happens after diagnosis? And for me, I'm a second and third opinion kind of doc. I mean, I think it's important to really get your ducks in a row and get some real science behind what you've been diagnosed with, not just the internet and your best friend.
Absolutely. And I agree with you. And I'm going to break it out a little bit into the way that traditional medicine looks at it and the way that functional medicine looks at it. And I think it's important to make that distinction because I don't think it's one or the other. I think it needs to be both. So the way that traditional medicine is going to look at it is that they're going to stage you by the traditional staging system. So the traditional staging system looks at what the size of the tumor is. And that is largely the function of how long that tumor's been there, with some rare exceptions. There are some tumors that are very fast growers, but most breast cancers grow at a slow to moderate pace. So they're going to look at the size of the tumor. They are going to look at whether or not there's nodal involvement. So whether or not the cancer has remained just in the ducts of the breast, or whether or not it has traveled to the lymph nodes underneath the arm, which is the most common place where breast cancer travels to first. But we're also looking at the behavior of the tumor. Is it answering to estrogen and progesterone, which are the dominant female hormones, and can we use those hormones to manipulate the tumor? Does it have a protein called HER2 on its surface, and can we target that? And the main purpose of staging is to determine treatment, because if everyone who has early stage disease is going to get surgery to remove the cancer. So the nuances there, what kind of surgery you get, that's mostly up to the patient. With rare exception, unless you have a very advanced cancer and you need a mastectomy, most of the patients get to choose if they want to have their breasts removed or have breast conserving surgery, and the outcomes are the same. We don't punish women for having a breast removed or choosing to keep it. The outcomes are the same. So the main reason to stage people is to determine what kind of systemic treatment do they need. What kind of chemotherapy do they need? What kind of hormonal therapy do they need? And so that's the purpose of staging. But none of these traditional treatments answer why you got breast cancer in the first place. So none of these traditional treatments address your why. And unless you get rid of the thing that is causing the breast cancer, the thing that serves as a source of inflammation, since inflammation is kind of the spectrum on which breast cancer and all chronic disease develops. So unless you get rid of that source of inflammation, you may get over this breast cancer and you may have a recurrence down the road. You may get over this breast cancer and you may die of heart disease, which is the number one thing women with breast cancer die of. So the number one thing women with breast cancer die of is not breast cancer, it's heart disease. And it's the same inflammation that's leading to the breast cancer that later leads to heart disease. So that's why the interventions, functional interventions, are not only important during the time that they're treated for breast cancer, because they improve outcomes from chemotherapy, they diminish side effects in chemotherapy, but it's so important for afterwards because they want to change their path, they want to change that trajectory so that they're not met with the diagnosis again or another diagnosis that can be even worse. Does that make sense?
Makes great sense. I mean, it gets back to what we discussed before, is about getting to the root cause, whether we're looking at the GI dysfunction, the autoimmune dysfunction,
Yeah.
cancer. There's always this underlying cause. And yes, we traditionally, conventionally, it's masked with medications, and we want to go that deeper step. So it makes total sense. So when we're looking at breast cancer, what do you see the differences in premenopausal and postmenopausal breast cancer? Is that presentation different? And also, how are we comparing to other countries when it comes to breast cancer? Are we more? Are we less? Are they doing something different than we're doing?
Well, as the rest of the world becomes more Americanized, unfortunately, they start to look at Americans. So as the rest of the world, takes to the Americans' habits of eating out of convenience and eating convenient foods, and they're gaining weight, and they're starting to have more diseases that go along with that really pro-inflammatory diet. So they're having more obesity and hypertension and diabetes and breast cancer and prostate cancer. They're catching up to us. But traditionally, when Americans were eating these highly processed diets and living these highly processed lives, and the rest of the world stuck to tradition, they did not have the problems that we have.
Okay.
So unfortunately, they're catching up to us. But I do think that there's more insight around the world than there is here. So for instance, the pesticides that we use on our crops, they're not allowed in Europe. They're not allowed to use those things because they realize the dangers. So there are standards around the world that don't exist here.
Mm-hmm.
And so until we realize, and until we as a country band together for the purposes of getting healthy and not getting wealthy, we're going to continue to get sicker, and the rest of the world will not follow our lead.
All right. And in that you said about obesity. So can you talk about the relationship between obesity and the prevalence of breast cancer?
Absolutely. It's really, in the most simplistic way, the more fat cells you have, the more estrogen you have. The more estrogen you have, the more growth that you stimulate. The more growth that you stimulate, the more likely it is that you're going to develop a cancer cell. So it's just a linear progression, and breast cancer is directly tied to obesity. And you don't even have to be grossly overweight, because where you can just be over fat. So there are a lot of people that maybe have skinny arms and skinny legs and just carry their weight around their middle, and they don't actually qualify as overweight when you look at just raw weight scales. But if your waist to hip ratio as a woman is higher than 0.8, then you are over fat, and that fat is very active. That's not benign fat. That fat is giving tons of harmful signaling to your body.
Gotcha.
So I don't focus on the weight number, but I do have everyone measuring their waist, measuring their hips, and dividing the waist number by the hip number. And if your number is higher than 0.8 as a woman or 0.9 as a man, you're at risk for not only breast cancer, prostate cancer, heart disease, diabetes, all of that.
Right.
So
that's a simple test they can do at home too. I mean,
that everyone can do.
Right.
Everyone can do.
Right.
So that's a really simple way to know if you're at risk.
For almost everything. I mean, it's just it's a giant, it's the red warning signal light is on, and
Absolutely.
you have to do something.
we talk about all the time. You know, I hate to bring COVID up because I know it's such a sore and sticky topic. But with the people that are at highest risk for having a complicated course of COVID are those with comorbidities
Sure.
and mostly metabolic comorbidities. And when I say metabolic, I mean you have high blood pressure, you have diabetes, you have heart disease. Those are the biggies. And the way to know if you're metabolically normal or not is to do that waist to hip ratio. And if you're falling out of that waist to hip ratio, that means that you're not metabolically normal. And unfortunately, in this country, you're in good company because
Right.
80% of Americans are not metabolically normal, and that's a problem. It's
That's a
a
big
problem,
problem.
and we're seeing it right now more than ever. We're seeing it right now.
So with breast cancer, do you see a difference in the premenopausal breast cancer patient and postmenopausal breast cancer patient? Is there one more than the other that we're seeing now? When it comes to prevention too, I mean, when you're looking at that, you know, when women go into menopause, what can they do?
Yeah. So, you know, the best thing that people can do in terms of prevention is make sure that that weight to hip ratio is normal. Like that's the best thing that everyone can do to prevent diseases of all kinds, like we talked about. There are all kinds of breast cancer, and I know that the traditional medical thinking is that, you know, you have, there are certain subsets of breast cancer, but by and large, everyone has the same disease. And it's just simply not true. So we see very aggressive breast cancers in young women, but then I've seen very aggressive breast cancers in older women. I've seen breast cancers in young women, which are like, we probably wouldn't have ever intervened in them had we not been highly screening that population. And I've seen breast cancers in women who are older, who, you know, they have like very aggressive courses, and then courses where they just say to me, you know, honey, I'm just gonna leave it, and they come back every year and it's the same. So, you know, it's like it's a spectrum. We have decided in this country, and I think it was the correct decision, to treat everyone aggressively, because you don't know which one is going to be aggressive and which one isn't. And I also think the biology of tumors changes according to what's happening in your life. So, you know, your immune system can sometimes hold it intact for a little while, which is why, you know, people can percolate along with metastatic disease, and then something happens and that chemistry changes from, you know, a physiologic kind of status quo to this stress chemistry, and then the cancer starts to grow out of control. So the thing about functional medicine and how we intervene differently is that we are constantly trying to get you into that that chemistry of happiness, of balance, of alignment, and keep you out of stress chemistry, because it's the stress chemistry that actually spurns on the growth of the tumor. And you can give all of the pharmaceuticals you want. When you are in stress chemistry, the tumor is going to win. And
So speaking
so
of pharmaceuticals, because, you know, we hear a lot in the office where they say, well, my doc brought up tamoxifen and said, well, if I want to go on it, I can, but if I don't, that's okay too. So what's the deal with that? I mean,
yeah.
when
And
did that become, like,
I'm
it's like,
not, yeah, I'm not quite sure where I guess there are some tumors that, you know, people perceive as being unaggressive, or maybe they're just a little bit estrogen responsive, and so maybe they think that tamoxifen is not going to make a difference or not. there's actually a test and a way of knowing if you're going to respond to a drug like tamoxifen, because you see if your enzyme is active or not active. But from a functional medicine perspective, I want to look at your estrogen metabolites, how you break down your estrogen. And I want to help you to make sure that you're clearing the estrogen in the way that you're supposed to be clearing it, and not making the tamoxifen, that not making the estrogen that leads to cancers. So it's really a different perspective. I'm not relying on pharmaceuticals. I'm trying to help your body utilize the pathways that lead to health.
Okay, so let's dive deeper. So somebody was given a diagnosis of breast cancer. Maybe they had a lumpectomy, a mastectomy. You know, they did biopsies. They had some treatment. Now they come to you. They should come to you. They should have been to you first, actually. So, what do you do? And if you can share, like, you know, how are you going to help this breast cancer patient?
Yeah. So first, I'm going to look at how they got here, because it's hard to move forward unless you understand your past. And a lot of people want to understand how they got here. I speak to so many women who said, you know, I did everything right. I did everything right. And it's not about determining that you did something wrong. I mean, the last thing that I'm about is blame or shame. But people don't realize, you know, the trauma that they had from a divorce or a parent's divorce, or that they were exposed or continue to be exposed to things that are damaging to their health, or they're marathon runners. They don't realize that that keeps them in a constant state of stress chemistry, because your body thinks that you're constantly having to run away from a saber-toothed tiger. And so I help the people discover what got them there, what their sources of inflammation could be. And then I really work with them to eliminate those sources of inflammation. And we do a lot of testing along the way. I find parasites and worms and organisms that shouldn't be there. And we work a lot on gut health, just like you work a lot on gut health, because people with breast cancer aren't any different than anyone coming to a functional medicine doctor. That, you know, it's all one system, right? And so you have to heal the system. You have to heal the whole person. You can't just cut a tumor out of breast and think that that's going to change anything. It's not. It may delay some things, but it's not going to materially change our health. So I work with them on all the things that build health, that drive health. So I work with them a lot on diet, because what we eat is important, but I also work with them on when they eat, because in order to have a healthy gut, you have to fast sometimes. You can't heal a road with traffic on it. So I talk a lot about fasting, but I talk a lot about mind, body, soul connection and the importance of that. And I help them, you know, work on those traumas and work on those relationships. And I help them, you know, find a way to find peace, and give them tools to give the things meaning that they want to have meaning, and not give the things meaning that don't serve them. I work with them on movement routines that feel joyful, and eliminating toxins and things that uh, trigger illness. So it's a process. Nothing happens in a day, and you know, we just work towards a healthier future. We build health.
Excellent. So I'm going to ask you this question, because we deal with this a lot when it comes to nutrition.
Mhm.
A lot of patients feel, listen, I'm going through this ordeal. The one thing that makes me happy is I want to have this Breyer's chocolate chip mint ice cream. And now you are taking that away from me. I'm saddled with this diagnosis. And the one thing I enjoy, now you're taking these things away from me. So how do you deal with that?
Let me ask you a question. What's the food that you enjoy the most?
The food that I enjoy the most, it's probably my turkey chops.
Your turkey chops.
And
Okay.
my sauerkraut. I usually my wife makes fun of me. My turkey chops and my sauerkraut.
Okay. So was that always your favorite thing?
No, growing up in Philadelphia, that was not my favorite thing. It was my soft pretzels.
Okay. So, and if I put a soft pretzel in front of you 10 years, let's say, how long have you been doing this?
I haven't had a soft pretzel probably over a decade or more, or
Okay.
haven't had a cheesesteak since I've been 19.
Okay. So let's say that I put a soft pretzel in front of you, let's say 15 years ago. What would you have done?
Uh, Probably would have rationalized a way to eat that.
And you would have devoured it, right?
Pretty much.
Yeah. Okay. And what if I put a soft pretzel in front of you now? What would you do?
Probably not gonna touch it.
Yeah. So what we like, what we love is what we know. And you haven't known a soft pretzel or a cheesesteak for a long time. So that's not part of you, right? So I always use this example of I am a recovering, I'll say recovered birthday cake addict. Okay, so I could eat myself a whole birthday
Mm.
cake. I didn't care if it was good birthday cake, bad birthday cake, homemade birthday cake, store-bought birthday cake, didn't matter. I loved birthday cake. My husband, God bless him, bought me a beautiful birthday cake this year. It didn't even bite. It
Mm.
just doesn't appeal to me anymore
Right.
because I have been feeding myself kale and onions and mushrooms and broccoli and kohlrabi and, and tomatoes and peppers. And, that's what I feed myself. And that's what I love. So what you love changes. And the people that come to me, they may come to me with a love of ice cream and cake and cookies and this and that. But when they leave me with a love for broccoli and kale and Brussels sprouts. And I mean, it's just what you focus on grows. And
Beautiful.
so you're not going to start off day one loving everything healthy, but the more nutrient dense food you eat, the more you love it. And so I don't impose those rules on people. I tell them like, listen, if you really want to have that ice cream, but do this first and then decide if you want to have the ice cream afterwards. It's up to you. And I want to keep an open line of communication. I have to keep an open line of communication. And I'm very clear with people that there's no judgment. You're going to eat ice cream, you're going to eat ice cream, and that's your choice. But eventually, what ends up happening is you go step by step by step, and eventually they're like, yeah, I don't even want that ice cream. It just doesn't appeal to me anymore. And it's actually a chemically driven thing because what we want, what we crave, is what our microbiome wants, those organisms that live inside of us.
Mm-hmm.
So if you replace the ice cream eaters with kale and broccoli eaters, and guess what? You crave kale and broccoli and not ice cream. So
Beautifully
it's
said. Beautifully said. So, what is your thought? So, there's two things I want to add. One, both you and I love the use of mushrooms. So, if you can talk about that.
yeah, absolutely.
Two, there are people that say, listen, I'm going to go all keto on this because we heard keto is good for cancer.
Mhm.
Or I'm going to go all plant-based because if you go plant-based, it's not going to return. So what are your thoughts on that?
Um, Pedo. Pedo is my thoughts on that. So let's do the keto thing first. So keto, the traditional keto diets are very animal product heavy.
Mm-hmm.
So it's a lot of meat, a lot of cheese, dairy, that kind of thing. And this is not only not a good diet for a woman, women generally do not do well on traditional keto diets.
That
So
is
for the
correct.
women who are trying to lose weight, they generally do not do well on these keto diets at all. Um, and all animal products are going to cause some degree of inflammation. And as the quality drops on the animal products, so does the inflammation rise. So if you're eating traditionally raised dairy, traditionally raised beef, traditionally raised poultry, you are getting way more of those omega-6 fatty acids, those pro-inflammatory fatty acids, and they're also going to stimulate growth in your body. The amino acids from them will stimulate growth in your body, and this will only serve to promote the cancer.
So when we say traditional, I mean conventional farming, conventional growth
Yes,
farming. Yes.
yes. Factory farming, that
Right.
kind of thing. Cattle that are raised on diets that are not their natural diet.
Right.
So
The
cattle
grain
that are
diets.
raised on commodity grain diets, corn and soy. Um, but that goes for factory farmed fish, which are also raised on corn and soy and chicken feed and things that are not in their diet.
Correct.
And it's also true of chickens. I mean, the chickens are being fed ground up disposable chicken parts as their food. So you have to be very, very careful about the source of your animal products. Beyond that, and I do push for veganism, but I push for whole food, plant-based, not there are plenty of junk food vegans, and that is not what I'm talking about at all. So what I talk to people about is a keto diet that is plant-based. And so it's not going to be strict keto in the way that it would be if you were just eating meat and cheese all the time,
Right.
because you are getting a significant amount of carbohydrate from the vegetables, but it's the vegetables that have all of the phytonutrients that are going to help your body to fight the cancer. And that's what I'm after. So I have a whole eating plan, which I prescribe for people, that is basically like eating the rainbow, along with healthy sources of fat, so that they are eating a keto type diet, because keto is good for cancer, but that they're not eating a keto diet, because that's bad for cancer. And no junk food vegans.
Right.
It's a
Right.
whole food plant-based vegan diet.
We see a lot of junk food vegans, and they come to the office
A
and they are
lot.
very, very sick. They are not healthy at all, and we have to work on that. And with that, we have to really work on the mindset. So strong. It's almost religious, like when they come in, the fervor behind it. Incredible. So we have to work on that mindset. If you can talk briefly
There's
about
a
mushrooms.
lot of orthorexy there, right?
Yes. A lot. They come in with, oh my, well, that'll be our next conversation. There's a lot of that. Can you talk about mushrooms? Mushrooms are absolutely wonderful.
So especially in the breast cancer population, because all mushrooms are aromatase inhibitors. So aromatase is the enzyme that makes estrogen. And so mushrooms are a natural aromatase inhibitor. So I have people approach me and say, yes, but I had a hormone negative cancer. Why do I need that? And the truth is that still that estrogen will spur more growth. So you definitely want to eat mushrooms as for their aromatase inhibition properties. But beyond that, medicinal mushrooms increase natural killer cells. What do natural killer cells do? Well, they kill cancer cells. And they prime your immune system to recognize these cancer cells as foreign, to kill them. But they also do other things, like they help your liver detoxify. So a very important part of cancer development is being overtoxic. So you want to get rid of all those xenoestrogens. You want to get rid of the chemicals in your environment that enter into your body. And the way that you do that is by boosting your liver function, and these medicinal mushrooms will do that. But they have abilities beyond just, the things that we can name. And one of the greatest things that I think is happening now with medicinal mushrooms is the work around psilocybin. So at Johns Hopkins right now, they're using psilocybin in the metastatic cancer population in order to reset their mindset and get rid of the stress, anxiety, all of that that surrounds that diagnosis of metastatic cancer. And in doing that, these people find a whole new peace, and it resets their chemistry from stress chemistry to that of peace, calm, happiness. And that's the chemistry in which bodies heal. So these people end up living longer just because they change nothing else, but they do a guided psilocybin trip, which is like a 3 to 6 hour experience, and that gives them a new lease on life, a whole new perspective. It's really amazing work. So mushrooms are absolutely magical and help promote our health through a spectrum of activities. So I'm a
Wonderful.
huge mushroom fan.
I love mushroom. Yeah, I feel about that. Okay, so we got a couple questions. So this is
Okay.
great. So I think you answered one, but I want to make sure I get you the whole question. So in case you want to add on to it. So someone writes, my wife, 33 years, BRCA2 positive, gone through 2 to 3 traditional therapies, surgery, chemotherapy. We'll do radiation plus a hysterectomy. After radiation, our primary concern is diminishing the risk of reoccurrence. How do we do that? And you touched a little bit on reoccurrence, but I wanted to give you that profile because I think there may be something else you want to add to that.
Yeah.
And then can you talk more about fasting? How does fasting help breast cancer, and how long of a fast would you recommend?
Right.
And there's been some
So
great work I saw with the fasting and the importance of fasting before you get chemo and how that was. So if you
yeah,
can talk to that as well.
yeah, absolutely. Absolutely. Um, so let me start off by saying that things are a little different in the mutation carrier population, in that they are already born with an inherent inability to fight breast cancers, all endothelial cancers. So cancers like breast, colon, ovarian, pancreatic. These are the cells that line ducts, glands. And in these people, we know that a large percentage of them will develop these cancers. And so we talk a lot about prevention and preventative surgery. So I know that you've already explored that and you have all of that planned. And then beyond that, because we know that not 100% of people who have these mutations get the disease, we know that there are things that are actionable. And those things that are actionable is how you eat, how you think, how you sleep, how you live, how you move, how you work, how you relate to the people around you, your life's purpose, your place in community, all of those things, your connections. And so, there's a book that there's two books that I really like. One is Radical Remission by Kelly Turner, and the other one is Anti-Cancer Living by Lorenzo Cohen. And I can put them in the chat
Yeah, that'd be
so
great.
that people have them. But there are things that you can control, and it's just about trying to live the best you can while still living. Right, you can't live, you can't avoid every toxin, but trying to live the best that you can, and really about creating a life of joy, of peace, because that is what is that that is what is going to grow. So what you focus on will grow. And if you focus on illness and sickness, and if you think that your destiny is going to be such, then that's what your destiny is going to be. But if you truly believe otherwise and you live your life otherwise, I believe that health can be achieved. Um, so, and again, I'll type those books into the chat box. And as far as fasting is concerned, the work of Walter Longo is just fascinating. So he talks about a 72-hour fast that is the day before chemotherapy, the day of chemotherapy, and the day after, where you are restricting your calories to a certain kind of calories. So it's mostly, it's a non-glycemic, non-inflammatory kind of calories. So it's a green drink and an avocado or a handful of nuts twice a day. So in and around 500 calories for those 3 days. And essentially what's happening is that you're shutting down access to glucose. Now, when our normal cells get shut down from access to glucose, they go into kind of a hibernation, rest, repair, surveillance phase where we look inside the cell and we say, are you normal? And can we re-release you if there's food again? Or are you abnormal? And do we need to get rid of you? So we go through this period of apoptosis where we get rid of the cells that are not good anymore, kind of involute and go away. And cells that are good, when we refeed again after that 72-hour period, they reawaken renewed. Now, cancer cells don't have that ability. They have lost that ability to become quiescent, to shut down, to hibernate. They are in constant need of glucose. So if you're shutting down their access to glucose, then what happens is they get really weak. They get very, they're testy, they're very friable. And when you give them a dose of chemotherapy, they don't survive it. They become very vulnerable in that phase. And so you allow the chemotherapy the most time it can without interfering with your health. So you give it about 36 hours after you've had chemotherapy, and then you start to refeed again in a normal way. And everyone's version of what that normal is different. The medical oncologist will tell you that it's okay to eat ice cream. My patients know that their normal is going back to eating the plant-based, high-fat diet.
Well, I mean, listen, you go onto any chemo floor where they're getting chemo. I mean, it's just filled with like cookies and cakes and it's just
horrible.
It's mind-boggling. It's just
yeah.
That's part of the problem, and it's just like, oh, go ahead, it doesn't really matter, and that's part of the problem.
So I think a large part of it is that when we think about the job of the medical oncologist, the job of the medical oncologist is to get people through chemotherapy. It's not to promote health. Right. And that's the main problem with our medical system, is that everyone has sectioned off into their separate suites, and their only thing is to get the patient through that acute situation with no regard to long-term consequences. So like all these chemotherapies are given with high doses of steroids. Steroids are the worst thing for the cancer patient. First of all, it brings on more insulin, more blood sugar, more growth for the cancer. But you have to remember that it's not the medical oncologist's goal for long term. Their only goal is to get you through the chemotherapy. So it's very conflicted, and there is a firm belief in the medical oncology world that calories and quality of calories don't matter. They associate weight loss with advanced cancer, And so they say, whatever you do, don't lose weight during chemotherapy. Well, guess what? For the overweight person, that's the worst
Right.
advice that they could give. That's exactly what they need to do during chemotherapy is they need to lose weight. So they're told to not lose weight, and then they end up eating garbage. And I've heard medical oncologists say, eat all these cream you want.
Yeah. So let me ask you this question then. So when you work with a patient who is also working with, oncologists and getting treatment, do you get any pushback? What is that conversation like? Have you been in that position where you have to make a phone call? I mean,
I'm in that position all the time. And I say to the patient, you knew coming to me in the first place that this was outside of the box. You were looking for outside of the box. Something about you knew that there was more, and I'm the more. There, everyone is not going to be accepting, but remember, I spent 17 years in this space, so I speak the medical oncologist language, and so we may not always agree, and oftentimes we don't agree, but I say to them, let's not fight about broccoli, right? So,
correct.
I'm asking you to go easy on the steroids, and you're going to make your decision on what you're going to do about that. But like, you're not going to fight with me about ice cream versus broccoli. Like, it's just silly, right? So, I have my things that I'm non-negotiable on. Like, I don't want you, do not hand my patient an Ensure or, whatever like garbage thing that you're pushing around there. My patient comes to their chemotherapy session with their green drink, and they know what they're drinking. They're not drinking Boost or any of those horrible things.
Boost and
And
Sure is horrible.
horrible, horrible.
Horrible.
We're poisoning the hospitals are poisoning the patients. But again, long-term health is not their goal.
Right.
Their goal is short-term management. We have an acute care system in a society of chronic disease.
That is true. True. All right. I've got two questions for you.
Okay.
One, how easy is it for someone to come work with you? So that's question number one. So we'll tackle that first.
Okay.
So how easy is it for someone to come work with you? What do they need to do?
So it's going to get much easier to start to work with me, because in the next couple of weeks, I'm going to be releasing my online course. So my online course is going to be like everything that you would get from me in one-on-one without the specific treatment. So I think that that's a great way for people to like enter into treatment with me. So you get to learn about all the things that I recommend. You have access to all the things that I've curated over the years, and you start on your healing journey. And then if you decide that you want more, you want to do the individual testing, you want to do the one-on-one, all you do is go to my website and apply for a discovery call. The discovery call is free, and it's me spending about a half an hour on the phone with you, learning about what's important to you, and seeing if it makes sense for us to work together. So, I try to make it as easy and painless as I can. It's hard for someone who hasn't started on this path, who isn't, doing plant-based eating, who isn't familiar with the pillars of health that we talk about in functional medicine. And sometimes people need that bridge to get started before working with me, because it can be really intense. But that said, if you're a newbie and you really, really, really want this, then, we just go slow and we work together over the course of 6 months, 8 months, 9 months, a year even. And we just make small changes that help to build health. Because for me, it's not a sprint, it's a marathon.
Absolutely beautiful. And when that course is ready, you're going to share that link so I can share with my people as well?
So it's all going to be available through my website, which is Real Health MD. And if you go there now and sign up to be part of my community, then you're going to get emails as soon as I release every new product. So The online course it should be up by September 1st, but my blog is there, and I am always putting things on Instagram. So if you follow me at Dr. Jen Simmons with 2 N's, if you follow me on Instagram, you're always going to get those daily tidbits, recipes. Um, I'm sharing my philosophies. I'm sharing information all the time on all of the media.
Yep. It's great information. I follow you. So it's great information. I see what you do. And I will look forward to that course. How long is the course? Do you know how long it'll be? So you can tell people?
So it's going to be 10 modules that if
Okay.
you listen
Beautiful.
to it all at one time, it would take you a couple of hours, but you can, do it in chunks. And then there's going to be lots of downloads that come along with it. So I think I'm going to offer it 2 ways: as an audio, as a visual, and then there'll be downloads for people that are going to listen to it just straight on audio. So that, I want people who just don't have the time to sit down in front of their computer and watch a video. I want them to have access to the information, and then they can just download the booklets.
Excellent. Beautiful. All right. And then one last question. I mean, we've already been talking for an hour. Probably have a half a dozen other questions in my head that we can keep going. So we'll save next time. We should probably talk about autoimmune, and there's all that to talk about, and stress and cortisol and so much great material to cover. So here's my last question tonight. What would you tell yourself, knowing what you know now, what would you tell yourself of 20 years ago, of 10 years ago? What would you have said to yourself?
Yeah, that's such an interesting question. I don't know that I would have changed anything, because I don't know that I would have come to this. I don't know that I would have believed unless it happened to me. So I think there's a purpose to everyone's journey. And listen, when I was feeling awful and I thought I was going to die, I didn't understand the purpose of my journey. And there are still days where I say, like, really, I have to suffer this much in order to help people.
Empathy,
But
compassion.
but I do. I wish that that with my colleagues, we all had a more opened mind. And I think in the traditional medical system, we're kind of taught, oh, where are the studies? Where's the clinical evidence? And people are all different and all individual. And so, we accept these medications and these treatments that are tested on, healthy 25-year-old men. And then, we wonder why they don't work on everyone else. And the truth is that, we're taught to think in this very narrow way. And it leads to, it doesn't serve people. And so, maybe 10 years ago, 20 years ago, 30 years ago, when I was actually studying and training, it might have been nicer to have a little more of an open mind and be more accepting and understanding. But I'm there now, and I'm privileged to be here. And I just want to spend as much time and energy as I can helping my former colleagues understand that there's more. There's more.
Excellent. Well, what a wonderful way to end this interview. Thank you so much again for tonight. Thank you to everybody who attended. So I'm going to hit stop recording and just hang on one moment. Thank you, everyone.
Thank you.